Hello, this is Anne DeGheest, and this is February 19, a clinical update. Some fantastic news this week. You don't want to miss it. We're going to talk about how your Neanderthal gene ancestors may be protecting you against the severity of COVID. We also for a lot of information on better efficacy data in the real world on the Pfizer and the Moderna vaccines. We also are going to review the new CDC guidelines. These are the things we've been discussing for weeks, but now it's official, on some of the things you have to do differently to protect yourself. And some other quick update on mutations and what's happening in the US, spreading of those cases. Let's get going. This is the clinical update on February the 19th. And if you have missed my first video, please take a look at the end of this. A lot of great news, 69% drop in the case rate in the US, 12% of the Americans have at least got one shot. In this video, you don't want to miss it. There's a lot of new data on efficacy of the vaccine. We're going to do a review of the vaccines, a review of the virus mutation affecting us, some side effects on the vaccine, the famous COVID arm, which I personally experienced. And the CDC, under new leadership, is now issued some new mask guidelines, including some of the recommendations we have been talking on these video channels for a couple of weeks. So a very interesting graphic here that shows you how do coronavirus carriers infect other people. And the infection rate is really when you're pre-symptomatic. You have been exposed, you have the virus in your nose, and around 45% of the infection are due to that period from the time you have been infected there to the moment you start developing symptoms, which is usually 3 to 5 days afterwards. That is really the big problem there. When you're symptomatic, a lot of people have mild symptoms there, and 40% of infection are due to that period there. And then really 10% of the infection are due to touching a surface, or all the concerns we had initially there about being in the environment there. And then the data is showing that really only 5% of people develop an infection after they've been exposed to somebody who was asymptomatic, because most of the infection is when somebody was pre-symptomatic, so they did develop symptoms. So the data seems to be indicating that asymptomatic people may not be as contagious as symptomatic people. So I wanted to congratulate you if you have 23andMe and you have some Neanderthal ancestors. It turns out I do. And the data just came out that you have a mutation on your chromosome 12. And that mutation basically has an impact on how your immune system is responding to this type of viruses. And it decreases your risk of getting a severe COVID by 22%. So I put a picture of one of my ancestors there that they emailed me from the other side. Just kidding. Now, you need to be aware that these mutations there don't exist across the world. There's none of that mutation in Africa, for example. It's a lot in Europe and in Asia. And so that's why we may see some of the difference of severity across the world based on some of those ancestors' genes. Another thing that just came out, we've been talking in the past about the long COVID. People have these long-term consequences. And in musculoskeletal diseases there, it triggers rheumatoid arthritis. And this is a picture on an MRI where you can see the inflammation in the shoulder that has been triggered by the virus, and it triggers autoimmune myositis. And more, there's a belief that the long haulers, which are people who have 10 to 30% of the population has problems after, several weeks after the disease, is really a trigger of autoimmune disorders. And to give you an idea, these are some of the data that has been done on MRIs and ultrasound Dopplers. And you can see all the findings in the muscles, the nerve, the joint, the soft tissue, and the bone. This thing is a train wreck across the body. This is in addition to what we've talked in the past about the heart, the brain, the kidneys, and the pancreas being affected. So pretty much every body part is under attack. Let's talk about the mutation. We'll talk about the 501. This is what basically how the virus attached to the ACE2 receptors. And there was a very interesting patient at Mass General. He had a live virus infection for 154 days. On the average, people have only live virus inside their body for maybe 14 to 21 days. But what happened, this person had a severe autoimmune disease. So his body was attacking the virus, but could never finish the virus. So the virus continued to duplicate itself. And because it was Mass Generals, they were able to do the sequencing of the virus. And what they discovered is that this virus continued to evolve. And guess what happened? It had more than 20 mutation, and it was a big cluster of mutation. It was like not at random there. It was like massive mutation there. And it was much faster and broader mutation than they expected there. And guess what it ended up at the end there? It ended up with that N501, which we call the UK mutation, which basically helped the virus attach more tightly to the ACE2 receptor. So it's basically easier for it to be contagious. And it ended up with the South African version, which is the E44K, which help the virus evade antibody detection. So clearly one of the problems we're having is that we need to really vaccinate the people who have autoimmune disorders, because what they think is happening in South Africa is that there was a very high percent of the population that had HIV, and that's how there was that mutation that comes from South Africa that has that 484 mutation and a 501. So it's an interesting case. The World Health Organization has already shown that in the UK, a mutation is now 25% of new infections in the world, so it's clearly spreading across the world. And the Brazil and South Africa are 4 to 5% of the new cases. So these two mutations are basically spreading. Let's go back into each of them. The South Africa is the B.1.1.7, and that's that mutation to the 501, which is the attachment to the ACE2 receptor. So it increased the transmissibility by 50%. It's already in 24 countries. There is 21 cases in the US, including Santa Clara. And you can see where it's happening here. These are the state where they have the highest amount of cases there. It is perceived that the Pfizer and the Moderna vaccine may be less effective against that mutation. And the Novavax shots, for example, appears to be only 60% effective against that mutation because they did a trial in South Africa there. And the J&J vaccine dropped to 57% effectiveness. So the South African B.1.351 is the one that we need to be careful, because we may need a booster or we may need to modify some of the vaccine. The 1.1.7 mutation, called the UK mutation there, there's two issues there. One is the PCR, which is a gold standard to detect COVID, may not be as accurate there because the reagent they're using for the PCR may create a false negative test. So if you have a positive test, you have it. If you're false negative, you may have been exposed. The problem of this mutation there is that it increased transmissibility by 70%. The UK has reported an increase of mortality by 30%. It's already spread in 80 countries. There's 1,500 cases in the US. And you can see that Florida and California have the highest concentration there. The good news is all the vaccine so far seems to protect well against that B.1.1.7. So if you got the Moderna, the Pfizer vaccine in the US, you're probably protected against the UK mutation that's spreading across the US. Data just came out today from Harvard that shows that doing a study in the nasal cavity there, that one of the difference in the B.1.1.7 is that the infection lasts 13 days. Where the typical infection in the Wuhan type of mutation there is much shorter of 8 days. And that explains why there's more people being infected, because you're more contagious longer. So the virus stays in your body a longer period of time. The viral load, interestingly enough, is the same, roughly. So it's really a function. So you can see the viral load there, the mean peak copies there, is really the fact it stays in your body much longer there. So therefore you're more contagious. Brazil is doing also some interesting experiments. So Brazil has picked a country called Serena in Sao Paulo state, and they're going to vaccinate the whole town, 45,000 people there, but they're going to do it in periods and stages and areas there. And what they want to do is they're doing one block, at a time there. They want to see if they're able to curb the infection. Again, we're trying to learn is that if you get vaccinated and you still have the virus, and are you decreasing the contagion there? And it's called Project S. And they had to keep it secret there because people were literally buying houses to qualify to get access to the vaccine. Right now, Brazil, as you know, had a huge problem there. They had a very high infection rate, and only 3% of Brazil has been vaccinated. They're having problem because they have made a contract with AstraZeneca, and AstraZeneca has a slowdown in their rollout. They're having problem in their manufacturing there. So they turn around and they made a deal with CoronaVac, which is a Chinese vaccine, and they're going to produce it in Brazil. In their own plant there. The problem is that vaccine has a 50% efficacy rate, so it's a lower efficacy rate. And the mutation in Brazil is called the P1 variant. There's been 4 states that have shown that mutation there. We don't really know. There's not enough data for us to know if it's more contagious or more fatal, or what are the issues with that mutation there. But you can see it's in Florida, but we'll keep an eye on it. So Finland now has a mutation. That's even more bizarre because Finland has a very low case rate compared to the rest of the world. They have only 735 cases for a population of 5 million people there, but they managed to get their own mutation there. And there's not enough data yet to know if it's more contagious and all of that. So we're going to basically hear over the next coming months more mutation. It's going to be part of our stories. So let's take a look at what's going on with the vaccine. Pretty much all the vaccines were targeting that spike protein. This is the spike protein that basically connect with the ACE2 receptors inside our body there. So the good news is 250 COVID vaccine candidates going down the pipeline. And we're going to be talking about the top 6. 2 of them are approved in the US, which is the Pfizer and Moderna, and we should probably expect J&J to be approved in the coming weeks. So there's 3 platforms. One is using mRNA, and that's the one you probably heard, which is Moderna and Pfizer, that allowed them to get the vaccine approved faster. And we discussed this 2 weeks ago in my video on February the 5th there, that this mRNA stays in your body for only a few hours before it breaks apart. It doesn't go into your DNA. There is no risk on that type of safety data. The other type is that you have a DNA inside an adenovirus, which is an existing type of virus there. And that's what AstraZeneca, J&J, and Sputnik, which is the Russian vaccine. And the third approach is to have basically a piece of the spike protein there with an adjuvant, which is the Novavax approach. So the great news, we got amazing data from the biotech industry, is that the efficacy for decreasing severe diseases, severe disease means you can get hospitalized and you're at risk of death or long-term problems, is pretty much 100%. So these vaccines are very, very effective. So don't get fooled about, some are 66%, some are 80%, some are 95%. What we're really looking for that reduction of severe diseases, and all of those vaccines which are rolling out have great data. One of the issues we're going to discuss is capacity. There is 14 billion vaccine dose capacity predicted by the end of 2021. And this is one of the problems. AstraZeneca was supposed to produce 3 billion vaccine. And this is where we have some of the delays. Same thing is for J&J. They have like 1 billion vaccine in the pipeline there. And Moderna is only, because they're scaling up as a new company there, they have only predicting 1 billion vaccine versus Pfizer at 2 billion there. So how does that all work out? The US has made several contracts there, and they made bet on 6 vaccines based on 3 different platforms. But you can see Europe basically made different bets, and same did the UK. That's why you're going to see a different strategy across the world based on what type of vaccine that they purchase. So for example, Europe is having a bottleneck because Pfizer had promised 10 million doses in December that they still haven't shipped. And in fact, there's a lot of resentment because the Europeans think he somehow got shipped to the US. That was 1/3 of the anticipated supply that didn't get shipped to Europe. Oxford and AstraZeneca had also promised a very high dose, which is approved in Europe, is now having a massive delay in the first quarter. So the European Commission turned around and bought additional doses this week, 350 million doses for Pfizer, with a clause to say that they won't buy it if there's a mutation there, a variant, that is no longer effective, which I think is interesting. And they also bought additional doses from Moderna. And so in the US, this was the contract that we had initially. If you remember, over the last few months, we bought 100 million doses of Moderna, 120 million doses of Pfizer. We basically increased that recently there, and the US has just bought additional doses, recently 100 million doses, both from Moderna. That gives us what we believe is all of those that we need, 560 million doses for the US to vaccinate the population there. Remember, this is only for adults over the age of 16. So let's talk about vaccine and immunity system there. And this is important to understand. In the short term, when you are a survivor of COVID there and you develop what's called antibodies, and B cells, but they don't last forever. They have a short memory, maybe 6 to 12 months. The T cells is what we're trying to understand better. The T cells are the ones that are not missiles as precise as the antibodies are. They're more like a general defense system there, but they are the ones that have a really long memory. And so what people are starting to study as we're vaccinating the population is how much CD4 and CD8 cells are we producing there, and how long do they last? Because that's what we really need to basically measure. And the problem is that it's really hard to measure. It's much easier to do a blood test and measure the antibodies. It's much harder to get a good measurement of T cells. So let's take a look at the top 3 vaccine. Moderna, which is the mRNA technology, is 2 doses. 15,000 people were tested before the FDA was approved there, and a very high protection there against hospitalization there. And the efficacy for mild disease is 94%. So, very effective there. Same as Pfizer, 100% efficacy for severe cases there, 95% overall. J&J has submitted to the FDA. Their meeting on the 26th, next Friday, and it's expected they will be approved. Now, they got some interesting data there. They were doing 3 clinical trials. In the US, they got 72% efficacy. In South America, 66%, and 57% in South Africa, because a majority of that population there had that South African variant there. So it is expected to be approved in the US. It's only 1 dose, and they have a pretty high capacity there. The next 3 vaccine coming down the pipeline is AstraZeneca, which is now approved in the UK and in Europe. It's 2 doses. It's a different technology. They use a chimpanzee adenovirus to basically be the carrier of the protein. And their data there is a bit messed up. If you remember, when they did their trial, they had one part of the trial that only got a dose that was half filled up. And that first dose at half dose with the second dose at full dose had a higher efficacy of 90% versus the people who were getting the 2 full doses there. So right now they're restarting. They have started some new trials with a half dose and full dose there. And so they're also having some delay in manufacturing capability there. Novavax is coming behind it. Their data is supposed to be released pretty soon. They're in their phase 3 data in the UK. It is expected, based on what they've seen so far, that it will also give that 100% protection we're looking for people not going to the hospital there. And again, they've seen a drop in their efficacy in South Africa, from 89% in the UK to 60% in South Africa there. And Sputnik, which is the Russian one, the data there is a little bit more easy as far as it being reviewed by independent experts there. They claim a 91% efficacy rate. Again, it's a 2-dose system. So Pfizer, as we discussed in the first video, but in case you didn't see it, this is a big breakthrough there. I published in the Lancet in pre-publication there today, show that after 1 dose and 2 weeks after your first dose, you have 85% effectiveness, that you basically have a very, very strong protection there. And that's the first time we've seen real world evidence that these vaccines work very, very, very strongly after the first dose. And the other thing that they have shown is that population they had the UK variant. 81% of that population, 81, had the UK variant. That means it is effective against the B.1.1.7 variant. So the other great news in that study there is that it decreased by 75% your contagious rate. And so they had a drop after the first dose of 75%. And that's great news because we knew they were still a carrier of the virus. We just did not know how contagious these people were. And it vindicated the approach of the UK to delay the second dose from 21 days to up to 3 months. And that's just so that we can use all the dose we have to as many people as possible, because it decreases the infection rate, it decreases the risk that you get sick, and you can delay up to 3 months is what they're thinking. The other great news that they released today is that the vaccine can be used in a normal freezer. And that has been a huge impediment in the distribution of vaccines because people had to get the super freezer. And so you can see that the FDA has been requested to change the label on the Pfizer to allow people to store in normal freezer. So this, to give you an idea, is the data that Pfizer did submit for their efficacy data a couple of months ago. And what they showed that you had the split of the curve. These are the people vaccinated because these are people get infected there. And the split was happening at 12 to 14 days after the first dose. And at the time, they calculated that maybe the effectiveness was 52%. And now, based on the Israeli data, we know that the real effectiveness in the real world is even higher than that. It's at 85%. It also showed the reaction. And so if you haven't got your vaccine yet, 83% of people have a local reaction, which is soreness and some swelling of the arm. Moderna, to give you the same, had a similar curve. After 12 days after the first dose, you can see you had the split of the curve there. So it is possible that Moderna, who was not deployed in Israel, may have the same type of high efficacy after 15 to 28 days. Now, Moderna had, 90% of side effects, locally there. And then they were reporting the systematic effect, which is headaches, fatigue, muscle pain, joint pain, and chills. And the other thing they have is the COVID arm, which unfortunately I got, which is you get a big histamine reaction there into your arm. And it's a delayed continuous hypersensitivity. So it can show up 2 to 7 days after you had the injection, after basically everything looks normal. It's very hot and red and firm. In my case, I had, 3 by 4 inches there. This could show it could be as high as 5 inches there. It seems to be more common in women. And it's only for the Moderna vaccine. It's not due to the mRNA. It's due to the additional ingredient they use, like the lipids, that people are reacting to. So in my case, I talked to a specialist from Stanford about what I should do before I get my second shot next week. And they say to really take H1 and H2 blockers ahead of time. And that's if you have had historically a histamine response to mosquito bite or any type of bites, you may want to basically load yourself up the day before and then maybe keep it for a week of Zyrtec at night or Allegra, during the daytime. And that's for one of the antihistamine, and for the other antihistamine, the Pepcid AC or famotidine, to basically help the body react. So I'm planning to do that. I'll let you know in 2 weeks what my experience is. So if you have a reaction there, when you get the vaccine, they're going to give you a link to basically register with vSafe, which is how the CDC is keeping track of these side effects. So after the vaccination, the CDC has issued new guidelines, which is technically you're not protected until at least 2 weeks after the second dose for the 95% rate. If for the 3 months after your vaccination there's no need to quarantine if you think you have been exposed. You still need to wear a mask. There's still a 5% chance that you could get infected there. And as I said, we're showing some data, you could still be contagious, although it's a lower rate. The viral load has been shown by an Israel study that is 4 times lower. But these are all recent data. So limited data, you still need to be cautious. So this is a data that another Israeli study that shows the viral load in the nose of people there. You can see there's a big drop in the viral load around that same 12 to 14 days. My computer is really funny today. Let's look at the immune memory. The data seems to indicate that after you have been vaccinated, there's at least a good level of antibody and T cells for at least 6 months. And we're really looking at a combination of the antibody and the IgM, and also this famous T cell that I mentioned earlier, the CD4 and the CD8. And you can see that most of the population at 6 months has pretty good protection there. This was just published in Science magazine. So another way to look at that is that they did some experiment in macaque, which is a type of monkeys, and they could show that after these people had been vaccinated there was a major drop in the amount of viral load there. And that ties to the data from Israel that shows in these 2 groups of 600,000 people there that you could drop the infection rate by 94%. In the symptomatic patients there, and by 89% for the asymptomatic. So a massive drop in infection rate, which may explain, some of the drop we're seeing in the US and in Israel. So let's take a look about children vaccine timeline. Everybody wants to reopen the school. Oxford and AstraZeneca have started a trial for the 6 to 17-year-old with 240 people where they want to show safety and efficacy. Moderna has started 3,000 patient trials there. Dr. Fauci today on the White House task force announced that he expects that maybe in the fall, we could get a vaccine available for the 12 to 17-year-old for the high school. But for the younger population, less than 12 years old, there may not be a vaccine approved until the beginning of 2022. And so that's going to be, that doesn't mean we cannot open the school, but that means we still have to basically be cautious and take precaution there. So let's talk about the protection triangle. It's really a combination of the being aware of the type of mask you wear, the ventilation, are you indoor, outdoor, what type of air conditioning system, and your distancing. All of this is kind of what you need to be aware when you look into an environment there. So the CDC, under the new leadership, has issued some new guidelines about wearing masks and really educating the population there about this triangle. First, you should try to get a mask that has a nose wire. It allows you to get a really good fit around your nose. It's also much easier if you wear glasses, to decrease the fogging of your glasses. Also, they recommend that you add layers of materials, have at least two ways to layer. One of the best ways that's available is to get a mask that has a disposable filter at 2.5 microns there in between the cloth materials there. Also, you should not combine two disposable masks because it doesn't improve your fit. You should not put a surgical mask or a cloth mask on top of a K95 or N95 because the N95 gives you the fit and you don't want to make the respiration even harder, which probably will put more pressure on the seams. So there is a technique called the knock and tuck, which is very hard to do. There's a video there, which I'll post on YouTube, but it's a way to use your surgical mask and knock them so that you have a better fit and less leakage around your mask. So the CDC now is coming up with things we've been talking for the last several weeks, which is N95 is the gold standard. You should be looking for the NOSH stamp. I'll show you a picture of it. That shows you it's been approved and meet American standard. The K95 is made in China. And unfortunately, 60% of the K95 are counterfeit. And the first sign to look is that if you have something that's attached to the earlobe versus that is not as good as something that goes behind the head. And that's how you get the tight fit. I would also post the FDA and CDC list of the NIOSH approved masks so you can see if the manufacturers is listed by the FDA. The next level of protection is the 3-ply surgical mask, which you can buy on Amazon. And that's where you do that knock and tuck, where you basically make it a tighter fit to minimize the leaking there. And then the next level after that is to have a cloth mask with a filter inside, and then double masking. And the double masking is to have a surgical mask, and then you put on top of that a cloth mask to basically make it tighter, so you have a tighter fit. So the CDC has shown a study that if you do double masking, you can block 92.5% of infectious particle. And then to give you an idea, a lot of these cloth masks are below 50% in protection there. So you really want to basically do that. If you have two people wearing double mask protection, it decreases by 96% the chance of an infection. So a mask with a nose wire gives you a better fit, and you can see how you basically put a surgical mask and then you put on top of that a cloth mask to basically give you a better fit. So this is another study that showed the drop in somebody who does the knotted mask versus people who don't wear any mask, and the infection rate and the amount of exposure you get. So you really want to be careful because although the infection rate is dropping, we still have these mutations that we're spreading around. So there's a lot of fake N95, around 14 million. Unfortunately, they got shipped even to hospitals. You need to look for the NIOSH approval mask. Take a look on the packaging. Look for trying to avoid ear loops if you can. Try to get headbands for a tighter fit. So if you look at the mask, you're looking for that symbol here. You're also looking for an approval number that starts with TC. And then you look for model number and a lot number. But really the big thing is that NIOSH logo. That's what you're looking for. So if you're on Amazon, take a look to make sure they have this. The mask mandate does work, as a study came out from the CDC looking at 10 different states that basically show a drop in 5% of hospitalization rate when there was a mandate after 4 weeks. So we still need to be cautious. We're not out of the woods. So some new drugs information. Israel again has come up with a new drug out of Tel Aviv that seems to have a big impact on 29 out of 30 moderate and serious COVID cases in the hospital there. It's again something that stopped that cytokine storm we've been talking in the past and moderate the immune system response. So it's something that can be inhaled once a day for a few minutes. So very effective in delivering there. So we need more data there, but that's very promising. We have an Amgen drug for long haulers. I got some good news for poor long haulers there when nobody's paying attention to them. This is a drug that was approved for heart failures in 2015 by the FDA. There's a small study, so it's only a 22 patient at UCSD. And they look at patient there that has basically uncontrollable heart rate, where the heart rate would be spiking. And while standing, and they had like huge problems like fatigue, weakness, and brain fog. And that's very similar to what we've seen with some of these long haulers there. And if you give it twice a day for a month, suddenly the heart rate, which was going up to 100 to 115 as you're sitting there, will drop to a normal range of 77. So these are good news as we're looking now to repurpose drugs for these long haulers. So stay positive, test negative, and get vaccinated. I'll see you in 2 weeks. And please, give me a thumbs up if you like these videos and help spread it to your network. So I'll see you in a couple of weeks. Stay healthy.